All right, we're going to talk a little bit about the childbirth process. When it comes to OB and labor and delivery stuff, if you look at all of the curriculum, all of those concepts, and all of the material that we have available to us, there's really four mindsets when it comes to dealing with the pregnancy patient and labor and delivery topics. So when those four mindsets we talk about, number one, we have the pregnant patient, and that's just another patient assessment. We have some specific conditions that we check for, some specific questions that we ask, but it's really nothing more than a patient assessment. The second mindset that we have is childbirth itself, the delivery of the baby, and that's what we'll talk about this afternoon. The other mindsets that we have, number three, would be the newly born patient. Again, it's just another patient assessment. We have some very specific things that we check for in terms of APGAR score, the pediatric assessment triangle, and such. And then the fourth mindset, it's progressive in nature. If things don't go well, then we have neonatal resuscitation. What we're going to talk about in this video is the act of childbirth. So when we talk about childbirth, the props that we have, this is the way that the child appears in the birth canal. This is kind of the positioning that we have. So it's important to kind of understand the concept of the position that the child is normally in. So this is normal or cephalic childbirth as we've demonstrated here. The baby's in the birth canal, positioned head down, ready to be pushed throughout the contractions, down the birth canal. We have the placenta, which is normally adhered to the uterine wall, and the placenta connects to the baby via the umbilical cord. So when we talk about normal cephalic delivery, one of the things that's really important to understand is after we've done our normal pregnancy patient assessment and we check for crowning, it's important to understand the concept of checking for crowning during the contraction, because as the baby's in the birth canal, what mom's uterus is doing as those contractions are happening, it's actually pushing and positioning the baby down the birth canal. So there's a difference in checking for crowning when mom is relaxed, in which case it's possible that the baby has regressed a little bit in the birthing process, has kind of traveled a little bit further back up the birth canal. And then when she's having these contractions, when her uterus is contracting, it's going to work to push the baby out. So when she has a contraction, that's when I want to check for my crowning or recheck for crowning if I've already done it once before. So I check for crowning, and as she's having this contraction, if I see any part of the baby presenting, I want to prepare for imminent delivery. So the normal cephalic childbirth, head first, as the baby presents, so I physically see crowning the top of the head. I know that he's in a normal position. I'm not worried about a breech delivery yet. We'll discuss that in a moment. So this is the normal cephalic childbirth. So as mom contracts and the baby begins to present through the birth canal, I simply take a gloved hand and I provide very gentle pressure on the top of the head, and that's just to prevent explosive childbirth. So I'm just being supportive as the baby presents. So a couple things right here. If we pause right here, one of the things to understand and to appreciate is that when the baby is inside the uterus, he's in that nice environment, that amniotic sac filled with fluid. So as the baby begins to present, if that amniotic sac isn't punctured, hasn't torn yet, the water hasn't broken, then all we want to do is simply pierce that very delicate sac, tear it from around the baby's face, and then the water will break, and then we can continue birthing the baby. The other thing is as the baby's head presents, if we notice any meconium, staining, or airway obstructions, this is the point in time that we want to suction that airway. And the reason is because as he squeezes through this birth canal, it's important to remember that this is the narrowest part of the birthing process. So if we conceptualize the fact that the baby is going to be pushed through the birth canal in this narrowed spot, if just for a minute, if we kind of fast forward, this narrowing of mom's anatomy, this is where the baby's chest is going to be squeezed. Once his chest is squeezed, then when he continues out the birth canal, his chest expands, and that's baby's first breath. So while he's still at this point in the birth canal, if we notice any meconium, staining, or airway obstructions, that's when we want to suction, because when he comes further out the birth canal and he takes his first breath, we don't want those things to travel into his smaller airways or into the lung space. Okay, so we've got the normal cephalic childbirth, right? I've very gently supported the head to prevent explosive delivery. As he delivers, right, the angle that the birth canal, mom's anatomy, is shaped, it's slightly downward and then very slightly differentiated at the end. So what that means is that the top shoulder presents first. And as that top shoulder presents, then I will slowly guide baby up so that the bottom shoulder presents. And then from here, let's pause just for a second. So here, at this point, everything else is pretty rapidly progressing from this point. I just want to make sure that I support the baby, that, that we don't have any mishaps. So as the baby's born, right, the umbilical cord will still be attached. And this is the point that we really begin our newly born patient assessment. So this is when we do things like dry, warm, position, stimulate, right? We have towels in the OB kit that we can use to dry and warm baby and make sure that he's vigorous. And we can stimulate if he's not vigorous and not starting to show that peripheral circulation and perfusion, right? So we dry baby, he's nice and warm, and the umbilical cord would still be attached. And then to position baby, it's best if we position baby on mom's chest, right? This encourages the production of a hormone that encourages mom to do a couple things. Number one, it's going to work on the cessation of bleeding through the birth canal. And number two, it stimulates the production of that hormone that then encourages the delivery of the placenta. And remember, when the placenta delivers, we want to catch that in the bag that's also contained in the OB kit. So when we clamp the umbilical cord, okay, so we've got baby with mom and the umbilical cord is still attached. All right, when we clamp the cord, most curriculum now says we're going to choose a point on the umbilical cord about 7 inches distal from mom. So if I choose about 7 inches and then I place that second clamp, right, and we use that milking technique that's shown in some of the other research videos, and I place that second clamp and then I wait for the pulsation to stop and then I simply cut between those 2 clamps. Okay? But most of the curriculum now says that it's not quite as important for us to clamp and cut that umbilical cord as quickly as we used to think. So now, if we take the time to make sure baby's okay, dry, warm, position, stimulate the baby, make sure he's comfortable with mom, then we can work on clamping the cord. All right, so now that we've talked about normal cephalic childbirth, let's talk about some breech presentations. Okay, so breech presentations, and for the sake of time efficiency, we're not going to utilize the entire birthing process. I'm just going to show conceptually what occurs during these breech presentations and then how we address those presentations. So we've showed the normal cephalic childbirth. Cephalic, the cephalus, just means the top of the head, which means that's what's presenting first. So anything other than the top of the head presenting is what's called a breech presentation. So when we talk about breech presentations, if we talked about the fact that when the baby is in this position in the birth canal, this being the narrowest point of that birth canal, that this is how the child fits through the birth canal and then goes on to that birthing process. So if that's the case, if I see just an arm present, just a hand or an arm present, this is the position that the baby's in. And there's not a possibility of childbirth from this position without a lot of trauma to baby and mom. So if I see a hand present or just one foot present, right, then this is the position that the baby's in. And if this is the case, this is also not possible for delivery without a bunch of trauma to mom and baby. So if I see a hand or a foot present, I want to put mom into, if she'll tolerate it, I'll put mom into a left lateral position, and then I'll support her and try to coach her and discourage the childbirth. I'll just try to coach when she has these contractions. I want to try to explain to her that her child is in a certain position and that if the delivery occurs during that position, it's not optimal for mom and baby. So if that's the case, left lateral position, treat mom with supportive therapy, oxygen if she needs it, keep her warm if she needs it, and try to discourage and coach through that delivery process. So that's the arm or the leg. While we're here, we can very briefly talk about a prolapsed cord. So a prolapsed cord, regardless of the position of the baby, a prolapsed cord is when a loop of the umbilical cord has protruded out of the birth canal. So if this is the case, it's important to conceptualize the position of mom and baby. So this is this is the potential with prolapsed cord. I have a section of the umbilical cord that is protruded through the birth canal, and the baby's weight could be on top of and compressing this cord, which hinders the circulation of this cord. Remember, this placenta is what's providing the baby with nutrients and oxygen and the things that he needs to sustain life prior to that delivery process. So if this umbilical cord has protruded out of the birth canal, we need to remember that this essentially is an internal organ. It's meant to be inside the body. Organs inside the body are warm and wet. When it protrudes out of the birth canal, there's a potential for it to become dry and cold. So in that case, in that essence, we would protect the umbilical cord the same way that we would treat things like the abdominal evisceration. When we see internal organs that have popped out into the outside world, I want to keep this warm and wet. So we never add any sterile water or any saline. We simply want to use its own moisture to stay wet. So I could take some plastic, maybe an occlusive dressing, and keep its own moisture inside, and then I can protect with either a trauma dressing or a blanket or a towel, and now I've kept it both wet and warm, conducive to its normal environment, or similar to its normal environment. The other thing that's important to understand here is that with the baby's weight on top of this cord, the potential for the circulation to be compromised is possible. So this is one of the instances in our curriculum where it's appropriate to utilize a gloved hand, insert the gloved hand into the birth canal, and I'm simply going to lift the weight of the child off of that umbilical cord. And if that's what restores the circulation in this umbilical cord, I'm now going to stay in this place, in this position, until I get to the hospital and I'm relieved by the labor and delivery doctor. Okay? But that's what's happening. The other thing to understand is that if you look at our Maryland state protocols, there's one instance where it talks about placing mom into the inverted position. That's when her head is down, her hips are up, and she's essentially on her knees and elbows. The thing to understand there is that if this is the normal, if this supine position is a normal birthing process, if this cord has prolapsed and the baby's weight is compromising the circulation, if I then invert mom into a head down, hips up position, the baby's weight will drop away from that cord and restore the circulation. So that's the one instance that we transport in that face down, hips up position. Everything else, if we have a breech presentation, I'm going to place mom in a lateral position if she tolerates it, support her with supportive therapy such as oxygen and blanket if she needs it, and then transport to the hospital while she's secured to the cot. So we've done normal cephalic childbirth, we've done some simple breech presentations, and we've done prolapse cord. Let's talk about a complex breech presentation. If the child will fit through the birth canal in this normal position, in its normal cephalic head first position, and the baby fits through the birth canal this way, it's also possible that the baby does fit through the birth canal in this position, right? The challenge here is that tissue being as elastic as it is, right? When we think about mom's anatomy and the elasticity of that tissue, if the baby fits through the birth canal, the narrowest point of this child is here around the neck. So the possibility exists that the child would deliver through the birth canal and then simply get stuck at the level of his neck, okay? So if this occurs, okay, what we can't do is we can't manipulate the child. I don't want to pull on any part of the baby and risk damage to the child while his head is still in the birth canal. I cannot insert a hand and pry the child's head out. So essentially the child is stuck in this position. This is the other instance where it's okay to take a gloved hand and insert it into the birth canal. So this is why I would insert my gloved hand into the birth canal and form a V, take my fingers and form a V around the child's airway. Okay, if I come to this side, I'm essentially going to make this V and form this pathway for air to make it into the birth canal. So this is the position that we're talking about. And all it does is it provides a pathway for air to come into the birth canal and reach the baby's airway. Because remember, this narrow part of the birth canal is where the child's chest gets squeezed, and then once it exits the birth canal, it expands, and that's baby's first breath. So if the baby presents in this manner, the chest has already been squeezed, it has already relaxed, and now he's working on taking his first breaths. So that's why I support that airway. If this occurs, then I'm stuck in this position until I get to the hospital, right? So we've talked about normal cephalic childbirth. We've talked about the breech presentations. We've talked about prolapse cord, and we've talked about supporting the airway in the 2 feet breech presentation. Let's talk about nuchal cord. Okay, so in a normal cephalic childbirth, one of the conditions that we have to look for as the child presents is the occurrence of a nuchal cord. Nuchal cord just means that the umbilical cord is wrapped around the neck. The hope is that as the child presents through the birth canal, and this nuchal cord is present, right? The internal organs being, slick and viscous and slimy like they are in their natural state, the hope is that I can simply take a finger, reach underneath this cord, slide it over and around the baby's head, and then the nuchal cord is no longer a problem. Where it becomes an issue is if this cord is wrapped so tightly around the baby's neck that I cannot get a gloved finger underneath this cord to pull it over his head, or it's simply too tight to pull over his head, in which case I would take my umbilical cord clamps and I would place a clamp, and then cut between and then just pull that cord off. The last condition to really discuss that we talk about a lot in the pre-hospital delivery stuff is the case of what's called placenta previa. So if we kind of break down that terminology, placenta previa, it's the placenta that is now first in the birth canal in front of the baby. So the placenta, which is normally adhered to the uterine wall, has become detached and is now blocking the birth canal from the baby. This is a really bad condition because what happens is, if the baby delivers or tries to push through this placenta, through the birth canal, this placenta can rip, tear, rupture, and this ends up being a lot of trauma and a lot of bleeding for mom and baby. So we want this to always be intact. That's why we catch it in the bag that's in the OB kit, and it gets examined by the doctor at the hospital. So in this condition, this is why we ask those questions to mom during the maternal patient assessment process. I want to know if she's been receiving prenatal care, and I want to know if she's been diagnosed with any high-risk complications. Usually moms that have this condition, sometimes they know. Sometimes they've been to their doctor and they know that they are what's called placenta previa. So in this case, as best I can, I want to discourage the childbirth. I want to coach mom through the process. As she's having contractions, I want to try to coach her to relax and explain the process to her. Explain to her that, listen, your placenta is blocking your child from delivering through the birth canal, and if that ruptures, it's very bad in the pre-hospital setting, so I want to discourage this as best I can. You can lay mom supine or in the left lateral position if she tolerates it. Treat her supportively with O2 and blankets if she needs it, and then transport to the hospital. And as with any childbirth, right, once the child has been born, whether it's a normal cephalic childbirth or mom actually delivers completely through the breech presentation, once you have the baby, it's now time to move on to that third mindset of assessing the child, assessing that newly born patient.